Yes, sir, it has been started. Thank you so much, sir. We'll start our session by invoking the blessings of Lord Saraswati. Let's join our hands to seek the blessings.
Saraswati namastubhyam varade kamarupini vidyarambham karishyami siddhir bhavatu me sada.
Thank you. I once again welcome you all to ISA Online PG classes. During the course of the lecture, all the participants will be muted and all the questions will be taken up later. You can switch on your videos if you are at an appropriate place, and I request you all to kindly stay muted. Thank you. Now, to begin with, I have with me Dr. Kriti, and Dr. Kriti will introduce our moderators for today and speaker for today.
Good evening, everybody. I welcome you all to another session of this ISA PG online classes. As ma'am has already pointed out that everybody will stay in the mute mode, and at the end of the class, we'll discuss all the questions. Let's start with our first moderator, our esteemed moderator from Himalayan Institute of Medical Sciences, Dr. Gurjeet Khurana. She has over 27 years of experience in trauma and neuroanesthesia, and she has various international and national publications. Our next esteemed moderator for today, ma'am, could you please move to the next slide, is Dr. Parul Jindal. She is President ISA Uttarakhand, and she is a professor and in charge pediatric anesthesia at the Department of Anesthesiology, HIMS, Dehradun. She has over 20 years of experience with difficult airway, pediatric obstetric anesthesia, and PG teaching. She is an instructor for CALS, BLS, and ACLS, and also an MD examiner. She is a guest speaker at various platforms and has been a president of DSA for the year 21-22. She has been organizing secretary for various Uttarakhand ISACON conferences from 2016 to 2000. She's a treasurer for UK ISACON 2017. She won the Diligent Award 2022, and she has been as president DSA. She won the second prize in ISH Narayani Award for Best E-Poster and has won many papers and poster presentation awards. She has 33 international publications, 25 national publications, and multiple citations online. I would like to welcome both our esteemed dignitaries, and let us start with the presentation by Dr. Purva Goyal, who is a postgraduate student at HIMS Dehradun. Over
Good evening,
to you,
everybody.
Dr. Purva.
Good evening, everybody. At the outset, I would like to thank the ISA Academics team to give us this opportunity to present a challenging case of challenges in a morbidly obese patient. We all know that there's an escalation in the prevalence of obesity throughout the world, which has led to an upsurge in the number of obese surgical patients to whom perioperative care needs to be delivered. Today, Dr. Purva will present the spectrum of the morbidly obese surgical patient from preoperative assessment to postoperative care. Over to you, Purva.
Good evening, everyone. Is my screen visible, ma'am?
No. Yes, please go ahead. You are visible and audible. You can start sharing your screen.
Yes.
Make it full screen, Purva.
Yes, ma'am.
Yes, Purva, your screen is visible.
Yes,
you may start.
Okay. Good evening, everyone. Today I'm going to present the challenges in a morbidly obese patient. The table of contents would be introduction, pathophysiological changes, the challenges, preoperative, intraoperative, and postoperative management, and special scenarios like lower segment cesarean section, laparoscopic cholecystectomy, bariatric surgery, ERAS in obese patient, and cardiopulmonary resuscitation in obese patients. Now, as we all know, obesity is a metabolic disease in which adipose tissue comprises a greater than normal proportion of body weight, which could impact health. Now, the WHO defines obesity as a BMI of more than 30 kgs per meter square. And morbid obesity as more than 40 kgs per meter square. CDC defines childhood overweight as a BMI greater than the 95 percentile according to the growth charts. Coming to the statistics, in India, 23% of the population is obese and 5% of the population is morbidly obese. The classification of obesity and health risk based on the body mass index, WHO has classified obesity as an 18.5 to 25 kg per meter square body mass index is normal, and it has the least ill effects on health. Then overweight is 25 to 30 kgs per meter square, which has increased risk. 30 to 35 is obese class 1, which is associated with high risk. 35 to 40 is obese class 2, which is associated with very high risk of morbidity. And more than 40 kg per meter square, which is also known as morbid obesity, is obese class 3, and it poses extremely high risk.
Purva, I would like to stop you here. There are some other terms like super obese, super obese, and ultra obese. So what do we mean by these terms?
Yes, ma'am. Ma'am, super obese means a BMI of more than 50 kgs per meter square. Super obese is more than 60 kgs per meter square, and ultra obese is more than 70 kgs per meter square.
Right. And what are the limitations of BMI?
Ma'am, BMI, one, it does not take into account the fat distribution, neither the fat composition of the individual.
So can you give me any example for this?
Yes, ma'am. Ma'am, as in the heavy bodybuilders or people who have a high amount of muscular mass, their BMI may compute to something high and go in the obese category, but when they're actually not obese.
Okay, right. Go ahead, please.
Now coming to the measurement of obesity, accurate measurement of body fat content is difficult, and it requires sophisticated techniques like a CT scan, MRI, or electrical impedance studies. But clinically, how we approach is through anthropometry using skin fold thickness, densitometry, body mass index, ideal body weight, and other parameters like waist circumference and waist to hip ratio. Which is an independent risk factor for ischemic heart disease, stroke, diabetes mellitus. It is considered to be high risk when it is more than 0.8 in females and more than 1 in males.
Purva, what sites can you measure the skin fold thickness from?
Ma'am, we can measure it from the biceps, the triceps, the subscapular area, and the suprailiac area.
And any other measures which are there for any other parameters that are there to measure the obesity?
Yes, ma'am. Ma'am, we can use dual energy abortiometry, and we can use sagittal abnormal diameter.
And the body volume index.
And body volume index. Okay.
Go ahead.
Yes. Now the distribution of obesity-induced morbidity. Basically, the fat in the is distributed in various parts of the body, but there is significance with respect to the metabolic effects and morbidity. So there are two types, basically the android or the central, and the gynecoid or the peripheral. So in the android or central obesity, the adipose tissue is predominant in the upper body or in the truncal area, which is here the fat is more metabolically active and has a high oxygen consumption, and hence there is an increased incidence of cardiovascular disease and metabolic risks, and it is more common in males. On the contrary, the gynecoid or the peripheral obesity, here the fat is mainly in the hips and in the buttock region and in the thighs, and it is relatively metabolically inert with less oxygen consumption, and it is associated with less with the cardiovascular issues, and this is more common in females. Now, coming to the etiology of obesity, the etiology of obesity is basically very complex and includes a variety of factors, but the main causes can be genetic predisposition, like in Prader-Willi syndrome. Then there can be medical disorders like Cushing's or thyroid disorders. Then drugs like corticosteroids. Then energy imbalance, like if there is the energy input is more than the output. Then psychosocial factors, ethnic influences, and socioeconomic factors. As in the developing world, the rich tend to be obese, but in the developed countries, the poor tend to be obese. Okay, the obesity-related diseases. So, in the psychosocially, it can cause depression, risk of suicide, social isolation, discrimination, low self-esteem. Endocrine or metabolic diseases include type 2 diabetes mellitus, metabolic syndrome. Respiratory system can have obesity, hypoventilation syndrome, OSA, sleep apnea, asthma, pulmonary hypertension. Reproductive system in both males and females, it is associated with infertility and also with menstrual irregularities in women. Musculoskeletal, these patients tend to have osteoarthritis and impaired mobility and flexibility. Cardiovascular, there is a whole array of diseases like hyperlipidemia, sudden cardiac death, biventricular heart failure, coronary artery disease, DVT, atrial fibrillation, where atrial fibrillation is the most common arrhythmia that is found in obese population. Then there's also venous stasis. In the gastrointestinal system, we can have NASH and gastroesophageal reflux disease. In genitourinary system, it is associated with chronic kidney disease, with kidney cancer, and there are also a wide variety of cancers that are associated with obesity. Coming to the pathophysiological changes in the cardiovascular system. So obesity leads to an increased circulating blood volume, which in turn increases the stroke volume, which leads to a further increase in the cardiac output, which causes the left ventricle to enlarge and increases the stress on the left ventricle, which leads to eccentric LV hypertrophy and causes both systolic and diastolic dysfunction, further leading to LV failure. Similarly, when in an obese patient, there is a high predisposition for obstructive sleep apnea, obesity, hypoventilation, leading to hypoxia, hypocapnia, pulmonary artery hypertension, which also causes right ventricular enlargement and hypertrophy, and thus leading to right heart failure. So therefore, in obesity, we see biventricular failure. Now, coming to the circulatory system, the total blood volume is increased about 70 ml per kg, and most of this extra volume, which is increased, goes to the adipose tissue. The resting blood flow to fat is approximately 2 to 3 ml per 100 grams per minute, and 1 kg increase in fat above the ideal body weight needs 20 to 30 ml increase in the cardiac output. These patients are also more prone for deep vein thrombosis. The reasons are chronic hypoxemia leads to polycythemia. Also, there is an increased fibrinogen, decreased fibrinolysis, increased intra-abdominal pressure, which leads to venous stasis and also immobilization. Now, coming to the immune system, obesity is a state of inflammation, basically because the visceral adipocytes, they release a lot of pro-inflammatory cytokines, which include interleukin-1, 6, and TNF-alpha. Also, insulin, which is actually an anti-inflammatory, it has anti-inflammatory properties. There's insulin resistance in obese patients. Also, increased metabolic rate leads to increased oxidative stress and promotes inflammation. Inflammatory cytokines also impair the neutrophil function, hence these patients are more prone for infections. So here we have to bear in mind that the timely administration of antibiotics is a must. Coming to the respiratory system, as we can see in this graph, there's reduced functional residual capacity due to decreased expiratory reserve volume. As the abdominal mass is increased, it pushes the diaphragm upwards. It can result in lung volumes below closing capacity in the course of normal tidal ventilation. Therefore, small airway closure occurs earlier. Atelectasis occurs, and there's VQ mismatch and arterial hypoxemia. Basically in obesity, we find both restrictive and obstructive pattern, but restrictive pattern predominates. So there's increased fat, decreased respiratory muscle function, which leads to decreased chest wall compliance and increased elastic resistance, which further leads to decreased total respiratory compliance in supine position, decreasing the functional residual capacity, the vital capacity, and the total lung capacity. These lead to shallow and rapid breathing and increased work of breathing, limited maximum ventilatory capacity. Also, FRC goes below the closing capacity, therefore small airway closure occurs, which leads to VQ mismatch and right to left shunt, and also arterial hypoxemia. Similar effects occur because of increased pulmonary blood flow, which decreases the lung compliance, and also chronic hypoxemia leads to polycythemia, and the same. Coming to the GIT or hepatobiliary system, here again we have a lot of diseases, like in the liver there can occur NASH and cirrhosis, hepatocellular carcinoma, there can be gallbladder disease, then there can be gastroesophageal reflux disease and various other diseases. Pathophysiological changes in endocrine system, there is hyperglycemia, insulin resistance, diabetes mellitus, metabolic syndrome. In the nervous system, due to diabetes mellitus, we may find autonomic neuropathy and peripheral neuropathy. Therefore, proper padding is needed intraoperatively. In the genitourinary system, these patients are more prone for acute kidney injury, and there is an increased incidence of eclampsia and preeclampsia. Musculoskeletal system, there's increased weight that leads to joint pains and arthritis. Hence, again, safe transfer is to be done for all these patients, even while transferring them from the trolley to the OT table, and then back again to the trolley, and then to the post-anesthesia care room bed. Then psychosocially, these patients have depression, low self-esteem, and social stigma. Now, there's a term called metabolic syndrome, which is also known as syndrome X. If there's presence of any of the three out of abdominal obesity, which is measured by waist-hip circumference ratio of more than 0.8 in males and 1 in females, high blood pressure of more than equal to 130 by 85 mmHg, increased fasting blood sugar of more than 100 mg per deciliter, decreased HDL, which is in males less than 40 mg per deciliter and in females less than 45 mg per deciliter, increased triglycerides of more than 150 mg per deciliter. There's another term called syndrome Z, which is syndrome X plus OSA. Now coming to obstructive sleep apnea. Obstructive sleep apnea is basically episodic complete cessation of breathing for more than 10 seconds, occurring more than 5 times per hour of sleep with a desaturation of more than equal to 4% despite maintenance of neuromuscular ventilatory effort. Obesity is the greatest risk factor for OSA. Now,
Purva,
sleep apnea.
What is the incidence of OSA in morbidly obese?
Ma'am, it is around 70%.
Okay.
Then, ma'am, sleep apnea occurs, it leads to sleep fragmentation. So since the sleep is disturbed at night, it leads to daytime sleepiness and decreased concentration and memory. Also, the increased carbon dioxide leads to cerebral vasodilatation and also morning headaches. There's another terminology called obesity hypoventilation syndrome, which is also known as Pickwickian syndrome. It is a long-term consequence of OSA. It includes a triad of obesity, chronic hypoventilation, and further leading to pulmonary hypertension and cor pulmonale. This is a sleep disordered breathing, and it has chronically increased carbon dioxide during wakefulness, which is the catch point here. Daytime hypercapnia, more than 45 mmHg, plus hypoxemia. The respiratory center is desensitized to increasing carbon dioxide concentrations. This is a diagnosis of exclusion, and the management is by overnight non-invasive ventilatory support.
So there was a case, actually it was mentioned by Charles Dickens, Pickwickian syndrome, where the patient where his character has obesity. So Purva, I would like to know how will you differentiate from OSA and OHS at this point?
Ma'am, basically in both of them, what is occurring, like shown in this slide, is fat tissue is present surrounding the upper airway, which leads to upper airway collapse and upper airway narrowing. Also, there is reduced lung volume, muscle weakness, impeded diaphragm motion, which leads to atelectasis. But when this is overdriven by low respiratory drive, which leads to ventilation perfusion mismatch and low PaO2, then it points towards OHS. And also, ma'am, the significant thing here is even during wakefulness, there is a rise in PaCO2. So daytime hypercapnia and hypoxemia point towards OHS, ma'am.
Good. Go ahead, please.
Okay. Coming to a similar term called obstructive sleep hypopnea. This is OSH. Here there is episodic partial reduction of airflow more than 50% for more than 10 seconds, occurring more than 15 times per hour sleep, with a desaturation of more than 4%. So comparing it with the earlier definition that I had mentioned of obstructive sleep apnea, where there was complete cessation for more than 10 seconds, here there's partial reduction, more than 50%. And also this was occurring more than 5 times per hour. This occurs more than 15 times per hour.
Purva, what is apnea and hypopnea index?
Yes, ma'am. Coming to that, this is apnea, and apnea-hypopnea index is the number of apnea plus hypopnea events that occur upon the number of hours of sleep. Now, the terms apnea and hypopnea here means partial or complete respiratory cessation, but this should be over a period of more than 10 seconds. Yes.
Yeah, no, continue, please. I'll ask you.
Ma'am, this is used to assess the severity of obstructive sleep apnea. It is given by sleep studies, polysomnography being the gold standard. The interpretation of this index is mild, 5 to 15. A lot of papers suggest that 5 to 10 episodes are up to normal. So if a patient has 5 to 15 episodes, mild disease, then weight loss, lateral sleeping position, and avoiding alcohol before bedtime would simplify things. Then moderate is 15 to 30 episodes per hour. In that, we can go for a CPAP or a BiPAP therapy for the patient around 2 to 12 weeks preoperatively. Severe, there are more than 30 episodes per hour. Here, we would like to advise the patient for a surgery, which is uvulopalato-pharyngoplasty.
So when do you advise a nocturnal CPAP or BiPAP in a patient?
Ma'am, here when patient is in a moderate
category. And
category.
What is a nocturnal pulse oximeter? Do you have any idea about it?
Yes, ma'am. Ma'am, nocturnal pulse oximetry, it uses, basically it is saturation monitoring overnight, where we have a probe which is attached to one of the 3 middle fingers, and it also has an oximeter attached to the wrist. So and then on the next day, we can take this off through a software. We can convert this information, and it gives us the amount of the trend of the saturation.
Evaluated. Yes.
Yes, ma'am. Now, the challenges that we basically are faced with when an obese patient presents for a surgery, one, he can have a wide array of comorbidities which may be optimized or may not be optimized in emergency surgeries. Then medication, they must be on various medications. Positioning would definitely be an issue in these patients. Equipment needs to be different for these patients. Difficult airway and IV access, ventilation, awake extubation, pain management, and DVT prophylaxis, all of which I will be discussing further. The point to note here is that these patients are very poorly tolerant to any stress factors during the surgery, like hypotension, hypertension, hypoxia, tachycardia, or fluid overload. So we do not have to let these happen. Coming to the preoperative evaluation, history taking, our history would focus on cardiovascular, respiratory, and the airway assessment. The most important thing here is the prior availability of any prior anesthetic records, with special attention to any events that occurred during induction or intubation of the previous surgery. The prior medical and surgical history, the drug history, the comfortable position for the patient of sleeping. So this is relevant because then when we're pre-oxygenating the patient, we might ask the patient to stay in that position. Then signs of gastroesophageal reflux disease like heartburn, excessive coughing, acid reflux, signs of OSA like daytime sleepiness, morning headaches. Also the use of NIV at home, inability to tolerate supine position. Now coming to the respiratory system, we will ask for shortness of breath, saturation less than 95% on room air, a stop bank criteria of more than equal to 5, BMI of more than 30, hypercapnia when awake, raised bicarbonates, hypoxia, exclusion of any other causes of hypoventilation. So the investigations that we can go for would be an arterial blood gas, spirometry, cardiopulmonary exercise testing, if we find it suitable as per the patient. The airway planning needs to be done because there is a 4-time increased risk of difficult intubation and bag mask ventilation. We have to also refer for further investigations and treatment. We should commence CPAP before surgery and continue it after surgery. Something to remember here is that if the patient is already a user of CPAP, we should ask the patient to bring the mask prior to the surgery when the patient comes to us. Then the BiPAP sometimes is necessary for improvement in symptoms. Plan for postoperative HDU or ICU admission if symptoms are not improved by the time of surgery. The patient can also have asthma. Like I said, obesity also may present with obstructive symptoms. So there can be dyspnea and wheezing. Asthma symptoms are common, but reversibility with beta-2 agonist is not always found. So cause is partly the chronic pro-inflammatory state from excessive adipose tissue and fat within and around the chest or abdomen, causing small airway collapse. So we can advise the patient for weight loss, which will, the symptoms from both classic asthma and fat-related wheeze, both will improve. Now coming to cardiovascular, we have to look for signs of heart failure, history of any cardiac syncope, increased systolic blood pressure, reduced exercise tolerance. So here we would go for a preoperative ECG and a 2D echo. We can refer to a cardiologist, and medical management and optimization before surgery is a must. Then for diabetes, mellitus, and metabolic diseases, deranged serum glucose, HbA1c, or associated complications can be present. We would advise to optimize the glucose control with referral to an endocrinologist. Avoid delaying surgery based on the HbA1c concentration alone. Now, the liver may be involved. So there can be evidence of cirrhosis and deranged liver function tests. These patients are usually thus asked to take a liver shrinking diet that is less than 1,000 calories per day, which can reverse the disease processes somewhat and actively seek components of any metabolic syndrome. Coming to the physical examination, we have to check for, other than the normal physical examination that we do for every patient, we would specifically try to look for the cervical fat pad, which would again be important to us for positioning during pre-oxygenation. Then we'd look for signs of right heart failure, like an elevated jugular venous pressure, distended jugular veins, hepatosplenomegaly, pedal edema. The ease of IV access, spine will be difficult to palpate, so we can think of a preoperative ultrasound assessment. And pre-existing neuropathies should be clearly documented on our PAC charts.
So Purva, as per the ASA classification, how are the obese patients classified?
Ma'am, usually they are classified as 3. So from normal to up to obese class 1 are ASA 1. Then obese class 2 is ASA 2, and obese class 3 and above are ASA 3, ma'am.
And of this classification of obese patient, which patient can you take for daycare surgery?
Ma'am, usually the patients, there are various ideas on this, but mostly more than 40 kgs per meter square without major comorbidities or optimized comorbidities can be taken up for daycare surgeries.
It's less than 40. Less than 40 with no major comorbidities.
Yes, yes, ma'am.
Go ahead.
Coming to the airway evaluation, we'd look for the facial or buccal fat, which would be important to us for bag mask ventilation. Mouth opening, neck movement, the TMJ can be restricted due to adipose tissue in the neck. We look for the Mallampati grading, which is usually 3 or 4 in these patients, large tongue and tonsils, excessive palatal and pharyngeal soft tissue. These patients usually have a short neck, so there can be decreased thyromental or thyrohyoid distance. Neck circumference at the level of the thyroid cartilage. Again, here, there are in various articles, they've said 38 or 39.5 or up to 42. So more than 40 centimeters is considered as a single best predictor of difficult intubation in obese. Also, these patients have large breasts, so we'd like to retract them during intubation. In obese, to sum it, we have a 5D situation, which is difficult bag mask ventilation, laryngoscopy, supraglottic AV device insertion, front of neck access, and extubation. To assess these patients, we would also like to go for a stop bang questionnaire, where S stands for snoring. We'll ask the patient if the patient has been told that they snore, is if the patient feels tired during the day, has anybody who is usually the wife or husband of the patient, have they observed them stop breathing during sleeping? Then P stands for pressure, which is hypertension, BMI of more than 35 kgs per meter square, age of more than 50 years, neck circumference of more than 40 centimeters, and gender of a male. So to interpret this, if the score sums up to 0 to 2, then there is usually a low risk for OSA. 2 to 5 is an intermediate risk, and 5 to 8 is a high risk.
So at what score of stop bang would you like to do an ABG or a polysomnography?
Ma'am, above 5 usually.
Okay, one more thing. The stop bang questionnaire का अगर आप interpretation लेते हो, तो अगर stop में सिर्फ stop का अगर आपका score more than 2 आता है, and if it is a male patient, or it is a BMI of more than 35, or if it is a neck circumference of more than 43 centimeters, then we say it is a difficult injection. Okay, or the patient has a high risk of OSA.
Yes. Then moving on to the obesity surgical mortality risk stratification score. Here we give a score 1 each for BMI more than 50 kgs per meter square, male gender, age of more than 45 years, hypertension, and any risk factors for pulmonary embolism, like previous history of venous thromboembolism, poor mobility, a venal cable filter already placed in situ, sleep disordered breathing, or pulmonary hypertension. And this is interpreted as class A, B, or C, depending on the score. 0 to 1 is less than 0.5% incidence of risk. 2 to 3 is 1 to 1.5% risk, and 4 to 5 is 2.5 to 3% risk. Now, coming to the MET scoring, since it would be difficult to assess the cardiac function of these patients, we can look at the MET scoring of these patients. Now, as we know, for any basic surgery, for a patient to tolerate any normal surgery, minimum MET score should be 4. So, at least the score should be more than 4.
Purva, you yourself said now that it is difficult to ascertain the cardiac function because of limited mobility and all. So yes, how do you assess it then?
Ma'am, first of all, in the history, we can ask the patient of how much, if they have any functional limitation, if they're able to do their daily tasks or not without difficulty. So that would be the MET questionnaire. Also, ma'am, we can get a transesophageal dobutamine stress echo done, because in these patients a direct echo would be difficult, so transesophageal would be more precise. Also, ma'am, we can ask them to do cardiopulmonary exercise testing, which would again be a little difficult for these patients.
And their ability to lie supine.
And their ability to lie. Yes, ma'am.
Yeah, these are few points which we should note, basically.
Yes, ma'am. Then coming to the Berlin questionnaire. So this is a 10-question questionnaire. The results, basically, if you get a 2 or more positive category, it indicates a high risk of obstructive sleep apnea, and this patient should be indicated for a sleep-limited study. Additional investigations that we can go for these patients are nocturnal pulse oximetry, transesophageal dobutamine stress echo, airway ultrasound, which involves a pretracheal soft tissue diameter of more than 2.5 centimeters, suggesting difficult intubation. Also, when we take the patient inside the OT, preoperatively before induction, we can do a quick focus and check for gastric residual volume of these patients.
So, Purva, what are the major determinants that influence the degree of post-surgical care?
Ma'am, one, the comorbidities that are present in the patient. Also, the OSMRS score, like I mentioned, if it is 4 to 5, that. Then, ma'am, the type of surgery, if it is a minor surgery, then it won't be such an issue. Also, ma'am, the presence of obstructive sleep apnea would be.
And obviously the competence level of the post-operative management team.
Yes,
right?
Okay. Now, before we proceed to any surgery in an obese patient, there are certain red flag warning signs that we should look for. These include poor functional capacity, an abnormality in the ECG, uncontrolled comorbidities, a saturation of less than 94% on room air, past history of DVT or pulmonary embolism, stop bang of more than equal to 5, OSMRS score of more than 3, and metabolic syndrome. Now, if any of these are present, then we can consider preoperative CPAP therapy, like I said, 2 to 12 weeks prior to surgery. Then we'll think of ABG, sleep studies, and echo. We'll book a bed in the HDU or ICU, and we can go for a cardiorespiratory referral. If these are not present, then the patient may be suitable for daycare surgery, and a battery of investigations would not be necessary then. Now, coming to the preoperative advice, we would like to hold any oral hypoglycemic agents, anticoagulants, NSAIDs, sedatives, and ACE inhibitors. Pre-medications, we would like to use benzodiazepines with caution. Antacids, fasting would be of nilper oral to us for clear fluids. And
Purva, just a note that in pre-medication, we should also add your antibiotics, like cefazolin. If the weight is more than 120 kg, then maybe you need to give a prophylaxis dose of 3 grams to curb the risk of surgical site infections. For nausea, vomiting, you can add dexamethasone to ondansetron and haloperidol. For postoperative pain, also, if you start your preemptive analgesia, which is now also known as preventive analgesia, we can use gabapentinoids, we can use melatonin and your NSAIDs. Then you can use thrombolytic stockings or low dose unfractured heparin or low molecular weight heparin to prevent the post-surgical development of thromboembolisms. So we need to keep all these things also in mind for your pre-medication.
So, Purva, there is a new term which is called as pre-rehabilitation. Have you heard about it?
Yes, ma'am.
It means that there is a process of improving the functional outcome of the patient prior to surgery so that post-operatively inactivity nahi ho, associated koi decline functions mein na ho. So in these obese patients, we know that there is a lot of micronutrient deficiency, there's mineral and vitamin deficiency. So it is better to supplement nutrition and micronutrients. And there is, जैसे आपने कहा कि liver shrinking diet दी जा सकती है less than 1000 calories की. Then CPAP का support अगर nocturnal देना है. Guiding the family and caretakers is very important. And there is a structured exercise program which needs to be done. But most important is your behavior with the patient. Please do not please do not be judgmental with these patients. Okay?
Yes, ma'am. Then if the patient is using NIV at home, we can ask them to bring the mask on the day of surgery. Also, consent and counseling, like ma'am said, of the patient and family both are very important because in these patients, in obese patients, counseling, cooperation from the side of the patient is very important. And like ma'am said, rehabilitation, which can be with, again, CPAP, breathing exercises at home, and try to reduce weight prior to surgery, and liver shrinkage diet. Now, dosing scalars. Total body weight is the actual body weight of the patient. Relative body weight is the ratio of the actual and the ideal body weight, where ideal body weight is the height in centimeters minus X, which is 100 for adult males and 105 for adult females. When the actual body weight exceeds the ideal body weight by more than 20%, the patient is said to be obese. Adjusted body weight is ideal body weight plus 0.4 times the difference of the actual and the ideal body weight. Lean body weight is the patient's weight excluding the fat. 80% and 75% of the total body weight for males and females. This is the lean body weight. For each X centimeter height above 150 centimeters, the formula for a male would be 50 plus 0.9 times X, and females 45 plus 0.9 times X, or it can also be calculated as 1.3 times the ideal body weight. Now, the volume of distribution is influenced by increased blood volume, increased cardiac output, decreased total body water, and altered binding of drugs. So in these patients, the hepatic drug clearance is usually normal, except if the patient has congestive cardiac failure and decreased hepatic blood flow. Renal drug clearance is increased because of increased renal blood flow and glomerular filtration rate. Drugs are to be administered based on ideal body weight, assuming it to be 100 kgs for adult males and 80 kgs for adult females. We'll discuss all the drugs separately right now. Subsequently, titrate the doses depending upon the response to initial dose. So this would be a tailored approach. So one approach to go about this is always pre-calculate your dose and titrate accordingly, intraoperatively. Now coming to each of the various doses. For induction agents like propofol, for induction we usually use the lean body weight, and for maintenance or infusion doses we usually use the total body weight. For etomidate and ketamine we use the lean body weight. For opioids like fentanyl, hydromorphone, remifentanil, again we'd like to use the lean body weight. This is because total body weight would pose an increased risk of respiratory depressant side effects. Then midazolam, again.
Hello.
I want to remove this.
Purva, any problem?
Hanji, ma'am. The bolus dosing would be by total body weight, and infusion would be by ideal body weight for midazolam. Paralytics, we can use ideal body weight for rocuronium and vecuronium. This ideal body weight dosing provides similar time to intubating conditions and avoids prolonged paralysis as seen with total body weight dosing. But for scoline, it is said that 1 mg per kg of total body weight can be used. Then reversal agents, we can use sugammadex and neostigmine according to the total body weight. Now coming to vasopressors, for epinephrine, norepinephrine, and phenylephrine. They can be either ideal body weight, lean body weight, or non-weight based. Antibiotics would be mostly total body weight for cefazolin and vancomycin, and piperacillin and tazobactam would be non-weight based.
Now, because of these different regimes which we follow for anesthetic drugs, it is seen that there's an increased incidence of awareness in obese patients shortly after the induction of anesthesia. Now, this is because what you have is that there's a rapid redistribution of IV anesthetic agents. So in order to reduce occurrence, you should always ensure that you've given the ideal dosing of IV anesthetic agent, whatever it is, like whether with the lean body weight or adjusted body weight, whatever has been given to us, you should have a prompt delivery of your maintenance anesthetic agents. And always be ready to give further IV boluses of anesthetic agent before any manipulation or any maneuver which we do. Ideally, I would suggest that you should prepare a chart of all your drugs which you have to give the patient according to his weight and according to whatever type, like lean body weight or adjusted body weight. So this will help you basically in always giving him the exact doses so that you don't overdose or underdose the patient. And it is always best to monitor the depth of anesthesia in these patients.
Okay.
Go ahead.
Yes, ma'am. Coming to the plan of anesthesia. So either we can use a general anesthesia or regional and local anesthesia, but both of them have their pros and cons. In general anesthesia, there are chances of rapid desaturation, hypoventilation, and apnea. Also, there would be a trinity of difficult airways. Like I mentioned, there can be difficult bag mask ventilation plus intubation plus laryngoscopy, reduced chest wall and diaphragmatic tone, increased incidence of atelectasis. There would be secretion retention, and short-acting agents like remifentanil and desflurane should be preferred. Coming to regional or local anesthesia, which is preferred, which can be given either by ultrasound guidance or fluoroscopy guidance, prevents the complications of general anesthesia, but here we would need special needles. Continuous saturation monitoring, epidural or peripheral nerve blocks decrease the post-operative opioid use and aid in post-operative analgesia. Technical difficulties are present because of obscured landmarks due to the excessive fat, and dose reduction is required 20% for local anesthetic agents.
Purva, आपने कहा technically difficult होता है because of obscured landmark. तो आप क्या कर सकते हो अगर आप spinal देना चाह रहे हो एक obese patient में?
हाँ जी, ma'am, we can use ultrasonography.
उससे भी simple क्या तरीका हो सकता है हमारे पास?
Ma'am, nerve.
What you can do is you can ask the patient to mark कि वो कहाँ पे नाड़ा बांधता है या अपना सर्वाइकल स्पाइन की जो प्रोमिनेंस है C7 की प्रोमिनेंस एंड ग्लूटल मास के बीच में ग्लूटल क्लेफ्ट जो है उसके बीच में एक लाइन ड्रॉ करिए इमेजिनरी, एंड दैट मीन्स यू आर इन द मिड लाइन. ठीक है,
Yes, ma'am.
प्लीज कंटिन्यू.
Now that coming to the technical considerations, so since these patients are relatively large, the equipments required are different. So for safe transfer, we can use the hover mat or the pad slide, which is like a plastic slide through which the patient can be transferred from one bed to the other. Then these require special OT tables. The traditional ones that we have usually weigh 180 to 220 kgs, but for these we require somewhere between the 450 kg tables which are available. Then we would need longer needles, spinal and epidural needles for these patients. We would definitely require trained staff. The emergency airway card should always be ready for these patients, and a standby surgeon for front of neck access should be available. The positioning in these patients, we would like to use the ramp or the head elevated laryngoscopy position for intubation, because it is also known as the ear to sternum position. This eases the intubation of the patient. Also, reverse Trendelenburg position can be used, but causes hypotension. Padding needs to be done to prevent any peripheral nerve injuries. We should strap the patient to the OT table, because for surgeries like laparoscopic cholecystectomy, where we do a right up and we put the head down of the patient, there is a high chance that the patient might fall off the table. Therefore, strapping is important. Also, pressure sores and neural injuries can occur, which would need padding. Coming to monitoring, the non-invasive BP measurement may be faulty. So we might require extra large cuffs. Also, coning of the cuff, coning of the peripheries occurs in these patients. Therefore, the BP readings may be wrong. Therefore, we can also go for invasive arterial monitoring or tensiometers, or there are devices which take blood pressure, non-invasive blood pressure readings from the fingers itself. Also, in such patients, we can try using the BP cuff on the forearm. Then we can insert USG guided CVP lines or IV access. Warming devices should be present. Blood sugar, or based on the blood sugar levels, there should be an insulin infusion. Then we can go for transesophageal echocardiography or pulmonary artery catheter insertion in cases of cardiac failure or pulmonary hypertension. Then neuromuscular monitoring in such patients is a must, because incomplete reversal of neuromuscular blockers is very poorly tolerated in morbid obesity patients. And coming to induction, the IV cannulation will definitely be difficult. So we can use ultrasonography and maybe vasodilatory creams. Then coming to pre-oxygenation, the pre-oxygenation we can use a CPAP of 10 centimeters of water. And
Before that, what can you do? Before that, what can you do?
Ma'am, 8 tidal volume capacity breaths, 3 to 5.
So that is more for an emergency patient. You have a patient, it is not an emergency, it's an elective. So how do you pre-oxygenate? What are the key steps? One, that you should at least have the patient upright head position of about 25 degrees. Place a ramp. Okay, na? Second,
Yes,
you start with a rightly fitting mask of 10 liters per minute for 100% oxygen. Okay, what else can you do? One, you can have a CPAP.
Yes, ma'am.
Or a pressure support ventilation. आजकल हम क्या करते हैं? What is the new techniques which you are using?
Ma'am, we can go for apneic oxygenation.
Okay, we can go for apneic. Now, please explain what is it?
Ma'am, we can terms like no desat or strive. Ma'am, basically what we do is through nasal prongs, we can, even during our intubation attempts, we can keep the nasal prongs.
Continue oxygenation.
Yes, ma'am. And also there are airway exchange.
और कोई टेक्निक है?
मैम जो एयरवे एक्सचेंज कैथेटर्स होते हैं हमारे उनमें भी, या फिर कुछ, हाँ जी
मैम, एक्सट्यूबेशन के टाइम पे आएगा ना?
हाँ जी मैम.
You can apply PEEP.
You can apply a PEEP.
We can apply a PEEP.
Or you can have Thrive. What is Thrive? Do you know that?
Yes, ma'am. Ma'am, it's transnasal humidified rapid ventilatory exchange, ma'am. Through that also we can apply a PEEP. Yes, ma'am.
कितने लीटर पे होता है?
Ma'am, around 10 to 15 liters.
Transnasal नहीं बेटा, that is around 70 liters per minute.
अच्छा, ma'am, 70.
हाँ, And please go ahead. We'll talk.
Ma'am, then we can intubate in the ramp position, which achieves alignment of all three axes. Then we minimize induction to ventilation interval to avoid desaturation. We can go for a rapid sequence induction with using short-acting agents, and a video laryngoscope would be very handy in such patients. Second generation LMAs can be used up to a BMI of 40 kgs per meter square, and we can consider intubating LMAs. And the last resort would also be awake fiber optic intubation. Then coming to maintenance.
Yes. Just a minute. There is a new technique which is called as the infrared intubation system, IRRIS. So here what happens is that you place this IRRIS is placed over the cricothyroid membrane, and it emits a blinking infrared light, and the flexible fibroscope which you're introducing does not neutralize this infrared light. And when you introduce your fibric optic, you can see this light blinking. Okay, it is displayed. So this is a kind of a glottic retrograde illumination. And there are single lumen tubes which have been developed, which have an incorporated camera.
Yes, ma'am.
Please go ahead.
Yes, ma'am. And coming to the maintenance, we use 50% air and oxygen, and we can maintain the patient on atracurium or cisatracurium. Then among the volatile agents, desflurane is preferred more than SIVO, more than ISO. Halothane is usually not preferred in these patients because there are higher chances of halothane hepatitis in the possibly already compromised liver. Then we can use pressure controlled ventilation, IE ratio with 1:1, and PEEP should be applied. Fentanyl and dexmedetomidine infusions can be used. Paracetamol can be given intraoperatively IV for pain control. Then head up position. During laparoscopy, there is due to compression of the IVC, there is a decrease in venous return, and also there's decreased renal blood flow and GFR. So we have to maintain the pressures up to a certain acceptable limit, not above 20 mmHg. Then post-operative nausea, vomiting prophylaxis, we would like to use ondansetron and dexamethasone intraoperatively. Dexamethasone after induction and ondansetron half an hour prior to extubation. And coming to the ventilation, we can use volume control or pressure control. Usually preferred in these patients would be a pressure control ventilation. The tidal volume calculation would be based on ideal body weight again, 6 to 8 ml per kg. Then again, the IE ratio, like we said, we can decrease the, we can keep it as 1:1. And then PEEP should be applied. PEEP causes an improvement in VQ mismatch and arterial oxygenation, but high PEEP also has adverse effects on cardiac output and oxygen delivery. It can cause hypotension. We can also use recruitment maneuvers.
And during intraoperative, you can use your lung protective ventilation technique. Like you should keep the driving pressure less than 13 to 15 centimeters of water. Use low tidal volume, 6 to 8 ml per kg. Target your FiO2 to around 0.3 to 0.6. Target your normocapnia. PEEP according to how much the patient can tolerate. Go gradually up to 10 to 12 centimeters of water. And after surgery, what we can do is we can use either CPAP or BiPAP.
Yes, ma'am. Then coming over to the fluid management, the fluid management should be based on the lean body weight. Our goal should be euvolemia, and we have to go for a goal-directed fluid therapy.
What do you mean by goal-directed fluid therapy?
Ma'am, basically it should be on the base. We have to avoid overload to the patient basically, so that we can do by various methods like pulse pressure variation or stroke volume variation or the.
No, it is basically, it is guided by patient's reaction or responsiveness to administered fluids. That is how your fluid response is the ability of the heart to respond to this fluid response. You know? Either it is an volume through increase of stroke volume, isn't it? So you need to see. How do you do that basically with the help of?
Ma'am, we use certain monitoring techniques, which can be like stroke volume variation, pulse pressure variation, or the plethysmographic wave form variation that occurs, or PICO, or ma'am flow track, but that would be a little invasive, semi-invasive procedure. And ma'am, we can also, if it were a non-obese patient, then we could have gone for a ultrasonography, but ultrasonography in this patient would be difficult. So
Yeah, and maybe the site is difficult, surgical site may be abdomen, so it is difficult, basically.
yes, ma'am. Yes, ma'am. Then, ma'am, pre-existing cardiac diseases, if present, then large fluid loads are not well tolerated, and these patients can develop a pulmonary edema. Coming to the extubation criteria, we should think of extubating these patients only once the patient is in a wake state with spontaneous efforts. The tidal volume and respiratory rate should be at the preoperative levels. Therefore, the preoperative documentation is important. The patient should be able to sustain a head lift for at least 5 seconds. A constant hand grip should be present. Effective cuff should be present. The patient should be obeying verbal commands, and adequate vital capacity of 15 ml per kg and inspiratory force of minus 25 centimeters of water should be present. Now, extubation strategy would be, we would prefer Sugamadex over neostigmine if available, because it prevents preoperative recuriorization better than neostigmine, and this is supposed to be administered after the second twitch in the TOF. So neuromuscular monitoring is important in these patients. We would like to extubate the patient in a semi-upright position, that is 30 degrees propped up, and with PSV, with PEEP or CPAP until extubation. Also, oxygen supplementation should be done throughout the transfer. Nasopharyngeal airway post-extubation can be placed, and in high-risk patients, we can go for an airway exchange catheter prior to extubation, which can be left in place for hours.
Purva, just a small note that 100% oxygen should be given to all these patients at the end of the surgery so that the PeO2 is more than 0.9. Okay? So you should always give 100% of oxygen before you start extubating, and always keep a nasopharyngeal airway ready with you just prior to emergence, and you can insert it.
Yes,
okay.
Moving over to the post-operative complications. So these patients are more prone to higher post-operative morbidity and mortality based on the pre-existing diseases. Increased risk of aspiration is definitely present in these patients. Then cardiopulmonary complications, there's twice the amount of chances of infection. Therefore, timely antibiotics should be administered. There's difficult weaning from mechanical ventilation. Increased chances of DVT and pulmonary embolism. Long NPO periods in these patients may lead to protein malnutrition syndromes, and there can be episodic arterial hypoxemia and post-operative cognitive decline.
We should be very careful with these patients in PACO. They should be closely monitored. Yes, they should be nursed in a head upright position. You should use standard oxygen therapy as well as use of CPAP or non-invasive positive pressure ventilation if needed. Following extubation, you should use high flow oxygen delivered by a nasal cannula may be used. CPAP should be considered in patients.
Sorry to interrupt, Parul ma'am. There seems to be a problem with your network. Parul ma'am, there seems to be a problem with your network.
No, my internet stability is okay. What we can do is I can just switch off my video and see.
No, now it is okay.
Now it's fine, ma'am.
Now you're audible.
Okay.
Yeah.
We should also consider about rhabdomyolysis, because this is a very important aspect of which will lead to AKI in these patients post-operatively. So we should look for some deep muscle pains or anything this patient might be having in the post-operatively. And always consider giving them oxygenation for at least 5 days, because if you consider these patients who have OSA or OHS, it depends on their REM sleep. This comes at around the second day, basically post-op. So always consider them to give them oxygen till up to 5 days.
Okay. Then moving, yes, ma'am. The post-operative management. So for thromboembolism, we would like to give them anti-embolic stockings. Then we should encourage an early ambulation in these patients. And if the patient had ongoing low molecular weight heparin prior to surgery, we should restart it. Then posture should be head up, breathing exercises, physiotherapy, incentive spirometry should be encouraged. Then we should assess the adequacy of ventilation at least for 24 to 48 hours, because most chances of respiratory dysfunction occurs on the second day post-operatively. Then intense monitoring should be there in the first few hours and resume non-invasive ventilation. But we have to remember that patients who've had a gastric bypass, in them risk of stromal dehiscence can occur with NIV. So in these patients, it should be used cautiously. Now the plan to keep the patient in which ward at what point of time. So the patient can be shifted to the recovery ward with the monitoring of pulse oximetry and ABG analysis, maybe 6th or 8th hourly in the first 24 hours. And non-invasive, the patient should be on oxygen support or non-invasive ventilation. And then the patient can be shifted to the HDU or ICU if the patient has had a major surgery or has a history of uncontrolled comorbidities. The patient can be discharged to unmonitored settings once it is safe, once the pain is adequately controlled. There is no significant risk of post-operative respiratory depression once the vitals are stable, once the patient is maintaining saturation on minimal oxygen support, and the patient is ready for, we should always be ready for re-intubation in controlled setup. As in, if in the post-operative area, the patient suddenly desaturates or aspirates, then it should we should always be prepared from earlier. Then multimodal pain management. In the preoperative time, we can go for gabapentinoids, NSAIDs, dexamethasone, and alpha-2 agonists. Intraoperatively, we can go for local installation of anesthetics, then regional blocks, then opioid-free anesthesia, where we can give lidocaine infusion, or we can use ketamine, or we can use magnesium sulfate or alpha-2 agonists like dexmedetomidine or clonidine. Then we can use our epidural. And then paracetamol, the dose should be maximum 4 gram in 24 hours. And if the weight is more than 50 kgs, then 1 gram IV 6 hourly would suffice in the post-operative period. NSAIDs and opioids, again, it is controversial. We should try to minimize the use of opioids because they can lead to post-operative respiratory depression. But if at all they have to be given, they should be lean body weight based. Post-operatively, these patients can have peripheral nerve catheters or PCA pumps or epidural. Now, patches should usually not be used because their absorption would be erratic and unpredictable due to the fat. Now, if a patient for obese patient comes for a lower segment cesarean section, the points to keep in mind is antacid. Antacid should be given half an hour prior. Then these patients will have difficult regional block, epidural to be placed early in labor, if at all. Then these patients will have a more difficult airway because already pregnancy is associated with a lot of airway edema. Then positioning of these patients would again be important because we have to we have to also go for left uterine displacement. Then panniculus retraction, whenever such a large amount of panniculus, the abdominal fat is retracted. If the patient is under spinal regional anesthesia, then it can cause a lot of irritation to the patient. Also, 2 expert anesthetists at least should be present for such cases. For laparoscopic cholecystectomy, there are various changes. In the respiratory system, the airway pressures would be increased, the functional residual capacity would decrease further, pulmonary compliance would decrease further, and the VQ mismatch would increase. In the cardiovascular system, the venous return would decrease further, systemic vascular resistance would increase, cardiac output will diminish, and the risk of arrhythmias, like I also said earlier, atrial fibrillation being the most common, would increase. Gastrointestinal, the risk of regurgitation is much higher. Neurological, the intracranial pressure increases and the cerebral perfusion pressure also increases. Now, in the challenges for a laparoscopic cholecystectomy, the position is head up and right up, so it leads to further hypotension, and also it can lead to endobronchial displacement of the endotracheal tube. Then capnoperitoneum can lead to either vagal stimulation and also sympathetic stimulation, hypercarbia, acidosis. Extraperitoneal insufflation can also occur, which leads to surgical emphysema, capnothorax, and capnomediastinum. It can lead to increased EtCO2, airway pressures, and also desaturation. Intraoperative desaturation. If this occurs, we have to consider the various causes. We have to check whether hypoventilation is occurring due to the capnoperitoneum, or if there is a decrease in cardiac output due to IVC compression, or if there are any arrhythmias, bleeding, or myocardial depression that's occurring, or is there any VQ mismatch that's occurring due to the decreased functional residual capacity, atelectasis, or if due to positioning there has been an endobronchial intubation or air embolism, aspiration, or pneumothorax. Then subcutaneous emphysema, if it occurs, we have to inform the surgeon. Now, these days, there's also an option of gasless laparoscopy. So here, there are peritoneal lifters or retractors. These avoid the effect of capnoperitoneum, and renal and splanchnic perfusion is also not altered in such patients. Also, in patients of carcinoma, the port site metastasis would also reduce. Coming to ERAS protocol for obese patients, the aim here would be to decrease the hospital length of stay and post-surgery morbidity. So earlier for colorectal surgeries, it was introduced, the ERAS protocol, but now they've been expanded to encompass even bariatric surgeries and other abdominal surgeries in obese patients. So for bariatric ERAS, they promote the use of laparoscopic techniques, avoid any prophylactic NG tubes and abdominal drains. Early postoperative feeding and ambulation are to be encouraged. Analgesia should always be multimodal. Antiemetics should be given, and thromboprophylaxis should be given. Now, the CPR in obese, here the defibrillator pad placement can get difficult. So the type of pads, instead of the defibrillator pads that we usually have, where we have to hold the pad, we would try to use a hands-off electrode. Why? Because it would be difficult to reach across the chest for the patient who is trying to provide the defibrillation, and more effort would be required for the CPR, difficult IV access, difficult effective airway securing, quality of delivered chest compressions would always be compromised. Efficacy and dose of vasoactive drugs needs to be kept in mind. The efficacy of shock and defibrillation. So the dose for defibrillation, same recommended energies to be used like normal individuals. Now, coming to DVT prophylaxis and bariatric surgeries, the patient categories who are at patients who are at higher risk for developing venous thromboembolism are aged more than 55 years, BMI of more than 55 kgs per meter square, who already have a history of venous thromboembolism or venous disease, or who have OSA, hypocoagulability, or pulmonary hypertension. The surgery-related risk factors would be if the surgeon is going for an open approach rather than a laparoscopic approach, if the surgical time is more than 3 hours, if there is any anastomotic leak present, if Roux-en-Y bypass has been done, if it is a revision surgery rather than a primary surgery, bariatric surgery if being done in the head-up position, and if the surgeon is going for an abdominoplasty. So the low molecular weight heparin dosing. For low-risk bariatric surgeries, we can use low molecular weight heparin or intermittent pressure pneumatic compression stockings or devices. And we can go for 3,000 to 4,000 of anti-10A inhibitor, anti-10A and international units subcute 12th hourly. And this is the same dosing for a non-bariatric surgery in an obese patient. Then if there is a high risk bariatric surgery, then the same, but the dose would be 4,000 to 6,000, and also extended LMWH is given for 10 to 15 days. Now, if a patient comes to us who has already had a bariatric procedure done and now is coming for some other surgery, the concerns that would be present in such a patient. So if the patient has had a prior history of sleeve gastrectomy, these patients should routinely be intubated, as there is a significant risk of reflux of gastric contents regardless of the presence of any symptoms of GERD. If the patient has had a Roux-en-Y procedure, then it may affect the bioavailability of oral medications as a result of shortening of the small bowel and loss of surface area. Therefore, post-operative analgesia absorption would be questionable. Then adjustable gastric binding, if that has happened, then high risk of aspiration despite prolonged fasting times. RSI with antacid pre-medication should be routine. Avoid any NG tubes unless acute abdomen or bowel obstruction occurs. The band should not be deflated. If considered essential, this should only take place after discussion with the bariatric surgeon using a non-coring needle and with full sterile precautions. Thank you.
Thank you, Dr. Poova. That was a very extensive and wonderful presentation by you. And thank you, our moderators, Dr. Parul and Dr. Gurjeet, for throwing so much light on this topic. May I proceed with the questions, ma'am?
Yes,
Yes,
please.
please.
Okay. So the first question here is that by Dr. N. Raghunandan, and he says, what are the risk factors of obesity?
So the risk factors of obesity could range from a wide contributing factors. One important thing is the genetics. If the mother or a father, but any one of the biological parent has any history of obesity, the mother has gestational diabetes. It could be weight gain during is a physiological phenomena after pregnancy. The females gain weight and increased central fat distribution is there. Then dietary factors could be one reason. Physical inactivity, then sleep patterns obstructed, जैसे हम सबसे ज़्यादा होते हैं. Anesthetist commonly, smoking cessation, and medications, certain medications like antipsychotic drugs, antidepressants, anti-seizure activities. So these can be some of the factors.
Right. Thank you, ma'am. The next question is by Dr. Malik. It says that should fentanyl buprenorphine patch preferably be avoided in morbidly obese patients? I think this has already been answered by Purva.
It has been.
Yes, so preferably not, right? Okay. Then the next message is by Dr. M. Srimant. It says HFNO, I think high frequency nasal oxygenation, help position during pre-oxygenation and intubation.
I think this means he wants them to be recommended. It's an addition.
Okay. One more suggestion by Dr. A.R. Raju says that single page guidelines provided by SOBA UK are very useful for quick referral, and every OR should have that available. So that is a suggestion for everyone. SOBA UK guidelines are very helpful for obese patients. One more suggestion by Dr. Raju is that Edward Company has non-invasive monitoring for fluid therapy for obese patient, for every patient, I suppose, but for fluid therapy. Okay. Okay. One more question by Dr. Vikas. What time after the surgery should feed be given to the patient? Okay. So NPO postoperatively.
See, this depends upon what kind of surgery the patient has undergone. If you've undergone a surgery under regional anesthesia or a block, the feed can be started within 6 hours. We are now progressing into the ERAs guidelines. So feed can be started as soon as possible, and depending upon the type of surgery, duration of surgery, intraoperative events, what is the BMI of the patient?
Right, correct. Okay, so ma'am, next question is, why is the IE ratio 1:1?
The IE ratio is 1:1 because of the expiratory phase. Because the patient has a restrictive lung disease. As we've discussed earlier, the patient shows both the signs of obstructive and the restrictive lung pattern, with the restrictive lung pattern being more common. So we need to have a balanced IE ratio here.
Okay. Okay, ma'am. The next question is, where do you put a BP cuff if you don't have an extra large cuff?
On the forearm.
You can put it on the forearm.
It is better to put on the forearm. The leg one is not so accurate if you put on the leg. So it is better to put on the forearm. And you have conical BP cuffs also available nowadays. Even they help in the measurements of these obese patients.
Okay. So the next question is, for how much time a nasopharyngeal airway must be in place after extubation?
This depends on the response of the patient. If there is no tongue fall, if you're not seeing any tongue fall, the patient is quite awake and able to monitor, keep his airway patent, we can remove the nasopharyngeal airway.
See, what is required in the post-op period is variability as well as close monitoring of these patients. We cannot just relax after getting a surgery done.
Now, supposing I'm giving opioid, so it is better to keep that nasopharyngeal airway in place there.
Plus the type of the surgery, the duration of surgery, and the site of the surgery.
Yes, site of surgery.
Are there.
Yes.
So there's no guideline as such.
No guidelines.
Okay, ma'am. So next somebody's messages, use of supraglottic device versus endotracheal tube. I think Purva has already mentioned that up
Yes,
to
she has
40,
mentioned about that.
BMI of 40, we may use a supraglottic airway device. But yeah, I think somebody wants to know like supraglottic versus endotracheal tube.
See, in supraglottic airway devices, it is seen, I mean, there is no such literature for more than 50 for the super obese or for the obese. But if the surgery is going to last for more than 2 hours, if it's a thoracic or an abdominal surgery, then preferably we should go in for an endotracheal intubation. And if the patient has a reflux, history of reflux, preferably then you should go in for endotracheal intubation. Otherwise, you can do it under a supraglottic airway device.
Correct, ma'am. Plus, I think she mentioned that second generation supraglottic airways are anyways
much better.
safer and they are better for
Definitely.
patients. Right. Okay. Why nitrous oxide is not preferred?
Postoperative nausea, vomiting.
Correct. Okay. About esophageal calibration tube and leak test.
Could you be more specific about this question?
The question, this is the only wording about esophageal calibration tube and leak test. I don't know. They have not mentioned the
Yes,
detail.
Dr. Kanchan can just elaborate her question so that we can take it up. Dr. Kanchan, please write
One more
the
question by Dr. Nigha. Can video laryngoscopes be preferred for intubation?
Yes, definitely. If you're well versed with it, you can definitely go for a video laryngoscope. Secondly, the vision is much better. The visual acuity is much better, but you need to be more trained. So that is more important. But video laryngoscopes, if you are well versed with it, please go ahead with the video laryngoscope because the vision is better. You can, the Cormick-Lihan grading is much better.
Right, ma'am. Okay. The next question is, when ETCO2 starts rising in bariatric lap surgeries, what changes would you make in ventilation pattern?
See, you need to maintain normal apnea. You can increase the respiratory rate. The IE ratio has to be changed. And first and foremost, please check what is the reason why the ETCO2 is increasing. So you have to take care of the cause.
Yes, ma'am. Plus, ma'am, PEEP भी थोड़ा add कर सकते हैं हम.
भी add कर सकते हैं, definitely.
Right. थोड़ा बहुत patient positioning का भी फर्क पड़ जाता है.
See, it can be divided into various factors like the patient factors, the surgical, the equipment failure. So we have to treat each cause as it comes.
Right, ma'am.
And definitely somebody has given us a suggestion. Tell the surgeon to decrease the intra-abdominal pressure. Yes, that can be done.
Okay, another question is how to maintain temperature during long duration surgeries in these patients.
Pardon?
How to maintain temperature during long duration surgeries in these patients.
I mean, we can use warm fluids. We can give, as we do for pediatric children, we can give them warming devices.
Warm IV fluids can be given. Monitoring of the temperature, beer huggers can be used.
Right, ma'am. Okay, so suggestion by Madhuri ma'am that video laryngoscopes are also useful if the patient has limited neck extension.
Yes.
Another question is, what is the easiest way of calculating LBW, lean body weight?
Okay, Purva, I think you are the best person to answer it now.
1.3 times the IBW.
All right. And how to calculate IBW?
Ma'am, again, 45 for males, 50 plus, and for the females, 45 plus, 0.9 times the height in above 150 centimeters.
Okay, कोई simple formula नहीं है कोई?
45.
See, the best way of remembering obese patient की calculations है या आपकी कोई भी चीज है, make a chart and then use it.
Right, ma'am. So a suggestion for all the PGs is that before you take up such a patient, you should make a chart of the ideal body weight, of the lean body weight, and then calculate the doses and then stick it on your OT machine, or you should have it handy with you.
Yes, that helps you a long way with these surgeries.
Right. Okay. Ma'am, there's another question.
The last question, Dr. Kriti. We are running short of time. So you can just please take last two questions and then we'll, wind up.
So can we use modified RSI in this patient?
Yes, yes.
And ma'am, do you recommend an RSI for all the patients who are obese?
No.
No. Only
No, not.
patients who give a history of a GRD or a full stomach.
And as Purva said, a previous patient who's already undergone a sleeve
sleep
gastroscopy.
That's all.
BMI more than 40.
Okay, ma'am. And what about aspiration prophylaxis? Do you recommend for these patients?
We give. In our
For
setup, we are
all
giving
patients.
for all the patients. We're very particular with two things: the DVT prophylaxis and with the fasting guidelines and anti-aspiration prophylaxis.
Plus, we can start with the stockings and DVT pump immediately after taking the patient
precisely.
in. Right. Just
Dr.
before
Parul,
onset
shall
of-
I ask this one add to the RSI?
Please, sir, please, sir.
Because the morbidly obese patient and the morbidly obese patient having a difficult airway are two different entities. You can't have the same thing associated with the morbidly obese. Many times you prepare everything for a difficult airway, and suddenly when you do laryngoscopy, it is just hanging there. The glottis is seen as wide as a total canal. At that time, you have to individualize the patients. You can't say the rapid sequence reduction in every patient. Aspiration prophylaxis, whether it's a morbidly obese or a normal patient, it should be done in every patient. I think that's the way to go with the modern anesthesia techniques and medico-legal aspects also associated with it. So rapid sequence induction, as far as these morbidly obese patients are concerned, I think that question was very relevant, how to maintain a temperature of these patients. I
Yes,
think
sir.
that is a very, very important question in the modern day when the patients, you can't have the buprenorphine or fentanyl patch in these type of patients postoperatively, hypothermic patient, going to the ventilatory, support later on. So maintaining an ambient room temperature is more important than giving the warm fluids, overloading the patient, giving them the covering sheet, which may not be sterilized at that time, interfering with the surgical field. So maintaining an ambient room temperature, which may not be comfortable to the surgeon, but that's where a compromise has to be struck in maintaining these type of patients for a surgical procedure. So you have to individualize every patient, considering a duration of surgery, considering other morbidly obese comorbidities of these patients. You have to individualize these patients. Now, I think two people had raised hand, Dr. Madhuri Kurdi and Dr. Naveen. Let them also give the suggestions.
I agree with Dr. Bajwa that in majority of the obese patients, it is the mask ventilation which is challenging. And you do a direct laryngoscopy, immediately the laryngoscopy and intubation is at times easier than the mask ventilation, but you have to keep all the things ready. Two, there was a lot of discussion going about the formulas and other things. Other formula which is very simple is total body weight. 80% of that you can consider in males as lean body weight, and 75% of the total body weight you can consider in females as lean body weight. And as you rightly said, all the calculations of the drug dosages should be done on the basis of lean body weight, except few of them like 5-pentone, succinylcholine, dexmedetomidine, 3 or 4 drugs. So definitely these do pose a challenge, but we have to be prepared. I think we have got two worst enemies, obesity and stupidity. So we have to take care of obese people. Thank you.
Thank you.
Thank you so much, sir. Madhuri ma'am, please.
Yeah, I think there was one question on the importance of 1:1 inspiratory-expiratory ratio for ventilation, right? So I would like to add to that there are various studies which have shown that the arterial oxygen saturation improves with this particular ratio of 1:1, and there is with a concomitant decrease in the peak airway pressures. That is why it is used. And a question for Dr. Purva Goyal.
Yes,
now, if you have a patient of severe obstructive sleep apnea, as you will have diagnosed from the whatever scores which you have used in the preoperative assessment, just tell me the main points like in your anesthetic perioperative management.
Ma'am, first of all,
Severe
preoperatively,
obstructive sleep apnea. Don't talk of OSA, only severe OSA.
Ma'am, first the preoperative part should be emphasized upon, and we can give the patient CPAP BiPAP therapy. If it is severe, we can go for uvulopalatopharyngeoplasty.
Next.
That is it. Then, ma'am, during induction, what we can do is the positioning of the patient would be very important. We would pre-oxygenate the patient in a head elevated position.
Okay.
Also, we would go for para-oxygenation, apneic oxygenation.
Done.
Then
Intraoperatively,
PEEP should be applied, which should be adequate, neither too much nor too less.
you will go more for loco-regional procedures. That
Yes,
is
ma'am.
advisable.
Then we would
Uh,
prefer. And then
yeah.
in the post-operative ward,
You will be careful with the
monitoring has to be-
extubation. You will be careful with the
Yes.
extubation and give the ramp position. Now,
Ramp
the
position.
airway parameters that you told in the preoperative assessment of an obese patient, if I ask you to number 1, 2, 3, 4, which are the most important ones compared to a non-obese patient? The airway parameters.
Ma'am, you mean matlab,
In
how
the
to
airway
measure?
assessment, yeah, preoperatively.
Ma'am.
If you compare obese with non-obese patient, how will you number the airway parameters in the decreasing order of significance?
Ma'am, the first one would definitely be a preoperative ultrasound of the adipose tissue, more than 2.5 centimeters.
Clinically, everyone will not have an
Ma'am,
ultrasound.
Neck circumference
Okay,
is the
next-
single best predictor.
Next.
More than 40. Then, ma'am,
Next one.
thyromental distance.
Hmm?
And the new literature also states neck
Severity of
circumference to-
obstructive sleep apnea by the stop bank questionnaire. Anything
Stop.
else? Anything else?
Yes, ma'am. Ma'am, newly they also suggesting neck circumference upon thyromental distance ratio.
What is extended Malampati score?
Yes, ma'am. In that, what they do is, like in normal Malampatti, we ask the patient to keep the head in a neutral position. But in extended
Yes.
Malampatti, we ask the patient to extend the neck. So that has a higher sensitivity and specificity of 0.94
It
sensitivity.
has a higher specificity, but a low sensitivity in the morbidly obese patient, right? Okay. And what are the challenges of fiber optic bronchoscopy in the obese patient?
Ma'am, first of all, the patient cooperation is very important in such patients.
That doesn't depend upon obesity. Anybody can be cooperative or non-cooperative.
Yes, ma'am. So while inserting the buccal pad of fat and the upper airway fat will have a role to play here, ma'am.
Yes. And when the bronchoscope enters an already limited pharyngeal area, which is full of fat, so
Yes,
the
ma'am.
patient will be on spontaneous breathing and the spontaneous breathing will be compromised.
Yes, ma'am. And
Okay.
in obese patients, the pharyngeal dilator tone is
Any
already
role of
observed.
gastric ultrasound in the obese patient?
Yes, ma'am. Definitely preoperatively, we can look for the gastric residual volume in such patients. So then,
The gastric antrum will be deeper as compared to other patients. Okay.
yes, ma'am.
Okay. Good.
Purva,
Thank you
is
so
there
much,
any
ma'am.
difference between the male obese patient and the female obese patient?
Oh, yes, sir, definitely. The pattern of distribution of the body fat, like I said, would be gynecoid and android. So gynecoid, even if the patient is obese, the fat distribution would be mainly in the buttock and thigh region, which is less associated with
I'm
cardiovascular
considering
and
about the anesthesia techniques, particular to
yes,
male
sir.
and female.
Yes, sir. So females would have larger breasts. So during intubation, we would like to retract the breast.
That is one point.
And the males will have beards. So, and plus heavier jaw as compared to the female. So bag mask ventilation would be more
That is
difficult.
everywhere. It's not about obesity, related to obesity. You know, the hormonal changes, changes in the obese female patients are quite a many. And considering your laryngoscopy stress, considering the other factors, considering your perioperative anesthesia technique also differs. How the females encounter the different stress period during the entire perioperative period as compared to male is entirely different. If you go to some deeper study now, when you will be consultant and you're going to deeper study, then you will come to know about these things. The hormonal changes play a very, very big role in the perioperative period, especially when it is obesity and gender-based obesity.
Okay.
Airway is one, then the rest of all depends upon the hormonal milieu.
Okay.
And that also depends upon the perimenopausal and the premenopausal.
Yes.
Thank you so much, sir. It was an extensive discussion. Ma'am, Dr. Madhuri, you want to say something?
No, I just wanted to add that goal-directed fluid therapy, which you all were discussing, how it is useful in the obese patient. So it also decreases the incidence of paralytic ileus, and there are studies which have shown that it improves the subcutaneous tissue oxygenation also in the morbidly obese patient. Just wanted to add that. Yeah.
And
Thank you
just
so much.
add on to you further, Dr. Madhuri, it
Yeah.
also prevents the biventricular heart failure also. Because these
Yes.
patients are easily dehydrated, as well as equally they can go into congestive heart also.
Yes.
So it's always better to go for goal-directed therapy.
Yes.
Thank you so much, sir. So I
So can I share an experience?
Yeah,
Hello.
please go ahead.
Yes, sir. So just in the recent past, I was doing an obese patient, and we were doing the hernia repair, extraperitoneal hernia repair. And as it is in that patient, maintaining the normocapnia was a little challenging, and there was sudden absorption of the carbon dioxide. And with each 2 minutes, the EtCO2 kept rising to a very dangerously high level, and it went up to 60. And so much so that nothing was helping. Changing the soda line, changing the ventilatory parameters, nothing was helping. Just EtCO2 kept rising, and there was tachycardia and there was hypertension. So I made sure that the patient was not light, but changing the ventilatory parameters did not help at all. And then finally, I had to ask them to stop the surgery. We reduced the intraoperative pressure and I increased the ventilation till the time EtCO2 came down to at least 40, and then we restarted. But sometimes in these patients, it could be very, very challenging to maintain the normocapnia. So we just
very
have
well
to keep
taken
that
point,
in mind.
ma'am. Yes,
Thank
yes,
you.
surely, ma'am.
Thank you. Yeah.
And I think the VQ mismatch plays a significant role in that. And we need to practice more and more ventilatory strategies in these patients. And recent advances, I think transpulmonary pressures are coming up as a strategy to minimize the atelectasis. So
Yes.
I think this discussion will go on, but I would
Yes.
like to thank Gurjeet ma'am and
Thank you.
Parul ma'am, our speaker, Dr. Purva, and my co-coordinator, Dr. Kriti, for this session. And now I would like to request Bajwa sir to take the session further and go for certificate distribution.
Thank you, Monica. There was one other point. We are concerned with the intra period. Now, these patients have to be managed by the surgeon in the post-operative period for a long time. We have encountered our first is the landing and this one taking off. So those are the two crucial periods of obesity. Now these patients, when in the post-op ward, I don't think so many of us are habit of going to the patient and see the patient, how they are doing, how they're recovering in the wards. Somebody told about the buprenorphine patch, fentanyl patch, because this patient has undergone some thoracic surgery, abdominal surgery, and you are using this patch and the vomiting comes, respiratory depression. Besides respiratory depression, there is a vomiting. The patient may not be able to breathe, may not be able to cough because of the pain, because so many factors are there. The discomfort level goes very high, and the maximum brunt, the clinician who bears the maximum brunt of the patient discomfort is the surgeon. It's not the anesthesiologist. We face those brunt which are amenable, which can be handled with the team. But in the post-op period, the maximum brunt is borne by the resident of the surgery. Ask the surgery resident how much nightmare he has during the wards. At the night time, 2:30 a.m., 3:30 a.m., continuously 3-4 hours, the resident is awake just to settle the patient or to provide comfort to this patient. I think here comes the role when we are doing the research projects on these patients. We should have a responsibility, combined responsibility to go to the wards, at least give one round in the evening when our residents are posted for emergency duties, or even in the ICU, they make it a habit to go to such patients who are, you can't go to every patient, but especially the patients who have undergone specialized surgery or the patient who are having high risk factors or other things, comorbidities. So that round has to be given, so at least to understand the empathetic and sympathetic factors associated with our branch, rather than just going about how to do airway, coming out with all the modern gadgets and techniques of doing the regional or technique of doing the intubations. Rather than these things, the biosocial perspective has to be taken into account while managing these obese patients. So the foremost thing for all the professors and HODs and the consultant is to teach the students to make it a habit to see these patients post-operatively, see how the fluid dynamics occur in the next 24 hours, how the pain perception in the next 24 hours, how the physiology gets, the homeostasis occur in the next 24 hours. The first 24 hours are always crucial. So I think our anesthesia curriculum should also penetrate into the post-operative period now, because such patients, they can create a lot of problem for everyone. I think you are called when the complication develops. I think to have better coordination in the coming times, to have a better fruitful relationship with the surgical fraternity or any fraternity, we should be now focusing on these areas rather than just modifying our techniques of managing. I think these patients have been managed from the time immemorial. Last 50 years, all our seniors have managed these patients very well. Their experience also counts. That has been taken into account while teaching the postgraduate students, plus newer techniques coming out, the newer medicine has advanced. So many things are taken into account. But now the biosocial perspective has to be taken a serious consideration while dealing with this patient, so as to provide a total good comfort to the patient. I have seen the corporate sector, they are trying to do these things, but in the corporate sector, the team is very limited. The maximum, the good consultants, they are not to be seen in the evening. Only the MOs will see the patient. But in medical colleges where the PG students are there, I think the third and second year student, they can give it a go. They can make it a habit. The professors can make a roster for these type of rounds. And that will help in the understanding anesthesia much better way. How your pain perception in the, I think the post-operative period, the drug plasma levels are good, but when the patient goes to the ward, the plasma levels decline like anything, and the hemodynamic disturbances, the pain perceptions, the other complications associated with anesthesia, they come into fore, and the person managing is the surgical resident, not the anesthesia resident. I think this requires a relook, reconsideration, and re-emphasis on extending our roles to the post-operative period. That's what I want to say regarding this thing. Anybody else want to give suggestion? They can give so that we can close this session.
So Dr. Raju, A.R. Raju has said that I was going for post-op rounds regularly, but I stopped as ward staff feel that I did some mistake in anesthesia. That's why I'm going for the rounds.
No, that has to be given by the professor. Is not, you can't go alone. You can't go alone. The order has to be taken out by the professor. There has to be a curriculum. I talked about the curriculum, not about the individual going. Individual going is always, can be taken into other ways.
So the change in culture is required.
Yeah, you require a roster for that. A roster has to be made for that.
And it is an excellent feedback on our intraop management also, post-op rounds.
Definitely. Awareness, you can always ask awareness when the patient is calm and composed in the ward. Awareness and other things. But we were talking at that time when the patient was being operated. So many things can be found out. Anybody else who want to suggest or something new? I think it's a good discussion today, and Purva has done a very wonderful job. Purva, great. I think you are much more luckier than Dr. Kriti. She was an examiner, a strict examiner, but you got a much. But here, Dr. Madhuri Gurdi was neutralized by.
No, sir, she was a very encouraging examiner as well.
I know that
she was very probing questions. She was probing answers out of us.
No, वो होता ना एक सामने फंस जाना तो मतलब फंस जाना होता है यहाँ पे. You have a escape route also. So before closing, I will share the certificates also for today's class. Just a gesture of our thanks for the ISA national gestures. The screen is visible?
Yes, sir. Yes, sir.
So this is for Madam Dr. Gurjeet Khurana. Ma'am, your certificate for today's.
Thank you, sir.
Dr. Parul.
Thank you, sir.
So rather being a teacher today, you are being a teacher of teachers today. So
sir, आप भी मौका देते हो.
ISA national मौका देता है, individual नहीं देता.
Thank you so much,
Purva, your certificate you have done wonderfully. Good job. I couldn't add one more line for a gold medal here. Okay. Dr. Kriti, again you are getting certificate even after passing.
Thank you, sir.
Dr. Monica, your wonderful role today as a senior facilitator.
Thank you so much, sir. But I just have a request. If Naveen sir can also bless us, because he was the one to introduce us to the ISA online PG classes.
He's always
So
there to
I'm
bless
getting
you.
the
He's always
certificate for the
there.
first time.
Hi, me too.
Yeah,
So
he's always there to
Naveen sir,
bless.
if you are there, so please bless us.
My blessings and good wishes. Rather, I can say my heart and soul is always in the ISA online PG classes. My mother, my wife, my maid, everybody knows that Monday morning, sir ko just don't disturb him, is in the ISA class. And you all are fabulous. Dr. Bajwa is carrying it forward and has taken it to the bigger platform along with the expanded team. Wish you all good luck. God bless you all.
Thank you, sir. Thank you
Thank
so
you
much.
so much, sir.
So let's end today's class. And the next class is on the very important topic. It's about the carcinoma of the oral cavity. It's and all the things related, anesthesia related, airway related things. It will be presented by Dr. Madhu Gupta and her team from Delhi. So we will be looking forward to the next class. Till then, I'm saying good night from National Headquarters and end by saying long live ISA.
Long live
Long
ISA.
live ISA.
Long live ISA and Independence Day greetings to all of you.
Happy Independence Day to all.
Happy Independence Day, sir.
Thank you.